Physiologic considerations and goals. The major pathophysiology in pulmonary hypertension is due to the elevated pulmonary vascular resistance, which increases the RV afterload, thereby increasing the RV work and decreasing RV and thus LV output. Based on the underlying pathophysiology, the major anesthetic considerations include: number one, preload. Maintenance of preload intravascular volume at normal or increased levels is required to maintain the cardiac output with increased right ventricular afterload. Systemic vascular resistance. In normal hemodynamic states, the systemic vascular resistance is a major determinant of the left ventricular afterload and therefore the cardiac output. In pulmonary hypertension, cardiac output is limited to right ventricular function and is therefore independent of SVR, systemic vascular resistance. In order to avoid the systemic hypotension, the systemic vascular resistance must be maintained in the normal to the high range. Contractility. Maintenance of normal to high contractility is essential to maintain the cardiac output in the face of increased right ventricular afterload. Heart rate and rhythm. Sinus arrhythmia or sinus rhythm is important for adequate filling of a hypertrophic right ventricle. Stroke volume is limited by ventricular afterload, so bradycardia should be avoided. Patients with pulmonary hypertension commonly have excess vagal activity. Avoidance of myocardial ischemia. Right ventricular subendothelial ischemia due to myocardial oxygen supply demand imbalance is common in pulmonary hypertension. Systemic hypertension and excessive increases in preload, the contractility and heart rate must be avoided. Hemodynamic goals in the management of pulmonary hypertension. Maintain the preload, normal to high. Maintain the systemic vascular resistance, normal to high. Maintain the contractility, normal to high. Maintain the heart rate and sinus rhythm. Avoid the myocardial ischemia. Avoid the increases in the pulmonary vascular resistance. Avoid the systemic hypotension. PVR, pulmonary vascular resistance. In pulmonary hypertension, PVR is the major factor governing the right ventricular afterload and cardiac output. Therefore, increases in the PVR must be avoided and therapy to decrease the PVR may be required. Avoidance of hypotension. Systemic hypertension precipitates right ventricular failure by decreasing the coronary perfusion of the right ventricle and by decreasing the contribution of the intraventricular septum to right ventricular ejection. Perioperative monitoring. Monitoring during anesthesia must detect the causes and complications of increased PVR. Arterial catheterization is also almost always indicated since hypotension may be precipitous and require rapid intervention. Intraoperative transesophageal echocardiography, that is TEE, allows continuous assessment of the filling and function of both the ventricles. Pulmonary artery catheterization can guide the therapy of systemic hypertension, but the risk and benefit of pulmonary artery catheterization must be assessed for each patient. After a small dose of midazolam, a radial arterial catheter is inserted. Pulmonary artery catheterization performed after the induction of the general anesthesia demonstrated pulmonary arterial pressure 65/38 with a mean pressure of 48 mm of mercury and systemic mean arterial pressure 65 mm of mercury. Cardiac output was 2.8 liter per minute. Choice of the anesthetic technique. Many anesthetic techniques have been successfully used in the individual patients with PH. Since general anesthesia in patients with PH has significant risk, peripheral nerve blocks should be considered when appropriate. The use of neuraxial techniques, spinal or epidural, may decrease the SVR and thereby produce systemic hypotension when the cardiac output is limited due to pulmonary hypertension. Epidural anesthesia is preferable to spinal anesthesia since it allows a slower onset so that the adverse hemodynamic effects may be recognized in early stages and corrected. Intrathecal and epidural narcotics may provide excellent pain relief post-operatively or during labor without producing sympathetic block. General anesthesia is usually required for major surgery. Isoflurane and sevoflurane and desflurane may produce beneficial pulmonary vasodilation, but decreased contractility and systemic vascular resistance can result in systemic hypotension. In general, patients with pulmonary hypertension with adequate functional reserve will tolerate the volatile agents. Nitrous oxide increases the PVR and should be avoided. In poorly compensated patients, a high-dose narcotic oxygen technique maintains the preload systemic vascular resistance and contractility without increasing the pulmonary vascular resistance. Use of 100% oxygen may produce pulmonary vasodilatation. Anesthetic induction is an unstable period during which patients with pulmonary hypertension are prone to develop the systemic hypertension and cardiovascular collapse. Propofol decreases the systemic vascular resistance. Ctomy is an induction agent in the adults may increase the PVR and decrease the contractility. Ctomy, which maintains the systemic hemodynamic without affecting PVR, is the drug of choice. Ventilatory management may affect the PVR. Hypercarbia is a potent pulmonary vasoconstrictor, and hypocarbia is a pulmonary vasodilator. PVR is dependent upon the functional residual capacity, such that the PVR is increased whenever the FRC is increased or decreased from its normal value. FRC is decreased during general anesthesia. This decrease in the FRC can be reversed with the positive end expiratory pressure, that is P. However, effect of tidal volume on PVR may similarly be bimodal. At low tidal volumes, alveolar hypoxia and hypercarbia may occur and increase the PVR. At high tidal volumes, excess lung volume results in compression of intra-alveolar vessels and increased PVR. Ventilation of the patient with the pulmonary hypertension should use high concentration of oxygen, moderate tidal volumes, rates sufficient to achieve mild hypocarbia and low levels of P. Now we come to the end of this session of lectures. In next video, I will bring you other informations. Thank you.